Everyone. Thank you guys for attending this morning. For those that haven't met me, Brandi Elliott, I am a paramedic and I've been practicing for about 20 years now. And I'm currently assisting with the PALS program, faculty staff doing ACLS, PALS, PAIRS, and BLS. Today I've come to spread some joy about EKGs and also share some information about the ZOL series. So I think we have Gwen, was it the Stifler on board? Who else is hanging around?
Sally, Lakin, Heather.
All right, good size group. So there is some part of today where I want some interaction from everybody because I'm done talking to Katie and Josh. They're not as entertaining as others. So when we do get into some rhythm interpretation, if anybody has any questions or want to work through some of them with me, please type up. We're going to move on to what our objective is today. We're going to review some basic anatomy of the heart, review the cardiac conduction system, practice some rhythm identification, discuss cardiac axes, not my favorite thing, and coronary circulation, and we'll do some 12-lead interpretation by the end. So we're going to jump into a video. I'd like to use a couple of videos just to help get an overall picture of what's going on with the cardiac conduction.
Remember, you're going to share your audio.
Oh, yeah. My lovely assistant is going to help me out here. 1 second.
I'm always in places like this to check my glucose, so I try to make it more comfortable. Lavender.
You ever try one of these?
The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation or ventricular diastole. The cycle repeats itself with every heartbeat.
So that was a good review for us for what is being produced on the printout, the EKG. Transition affected by PowerPoint, my little things need to hide away.
There's one simple hearing hack anyone can use to improve.
I want to watch that.
I know you want to watch that, however, my little screen needs to. Okay.
Also click and drag it out of the way.
You think so? Yep. I hope so. I want to drag this thing. Yeah, that makes so much more sense. So the next part we're going to go into is looking at the numbers involved with the cardiac induction. When we go to measure our P intervals, things just should be a refresher that we want to make sure it measures between 0.12 milliseconds to up to 20. It can be shorter in children, and the older you get, the longer your PR interval can be. And then for the QRS complex, it measures 0.08 milliseconds to 0.12 milliseconds. And children measure shorter, 0.04 milliseconds to 0.08 milliseconds. And then another number that we will be mindful of is the QT interval. QT interval for adults, male adults, is generally 0.350 milliseconds to 0.440 milliseconds for men. Women and children, always different. They're 0.350 to 0.40 milliseconds. So those numbers come into play later on. We're looking at the 12 leads, but just be mindful. Anyone that measures a QT interval higher than 0.50 milliseconds has a higher risk of having this arrhythmia. And then I looked at your result series that you guys use so that I could become more familiar with it, going over the EKG review. So just good skin prep techniques, things that we don't think about sometimes is having, the reason why they have the sandpaper on the back of the EKG dot so that you can brace the skin, get the hair out the way, or lotion so you have good skin contact, and also always make sure that the EKG leads are equal distance apart. Really put them on the limb leads on the limbs and where the proper pictorial leads go. My lovely assistant Josh is going to tell us later on with the 12 leads to show them a little quick notch trick or make sure we get proper placements of V1 and V2. So proper placement of EKG and proper technique for the morning is very important. Let's go into, once you place the patient on an EKG, what is your method? My method has always been I look at the monitor and take a good guess at what it is, or do you generally print it out and do a measurement? So what measurements are we going to do and what we're going to check is miles such as the R intervals to tell if they're regular or irregular. So skipping ahead to the R interval, you can look on the printout and compare using the small boxes or the big boxes, or you can use your ruler and measure out the distance if the R intervals are equal apart or unequal apart. And that may also put into play at determining what type of rhythm you have. The PR complex is there generally, but just determine if the rate is regular, irregular off the bat. We're looking at the RR interval, and also that will give us an idea of how fast or slow the rate will be. Once we get into determine if it's regular or irregular, we can go from there as in the other parts of how wide the QRS complex is it narrow, is it wide, and that's make sure we have the FT segment at the end as well. So just to get down a few basic practice of looking at an ECG rhythm, we're going to look at if the rate is regular, irregular, and determine the rate, and based on those two things, we're going to see if we can identify the rhythm. So this is the classroom participation. So let's say, who's the first one who talked earlier? Gwen gets to call out the first rhythm and describe what she sees on her, in front of her, as far as the R to R interval. Can you tell us what you see, Gwen?
Irregular.
All right. Irregular, anything else characteristic-wise, fast or slow? Or what was your rate would you give that? 6-second strip. What would you give that rate? Oh, Gwen went back out on me.
Do I get a vote?
Yes, you get the vote.
Okay, I'm actually not really good at EKGs, but this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 complexes in a 6-second strip. So I'm just gonna multiply that by 10 and say 100.
Okay. All right, so irregular and 100, anybody, who else is on there? Stifler hanging around there somewhere? Stifler paying us any attention?
Mm-hmm.
I'm there.
Stifler, what's the guess of, if it's irregular and a rate 100, what would be a good guess for that rhythm?
Well, it's irregularly irregular rate around 100, so AFib.
Yes, you won the prize for AFib. I guess my screen, I hit the button twice, but AFib, you didn't notice it was AFib until then, right?
Totally told us.
Oh, it's sons of bitches.
Brandi,
Mm.
that's right.
It does say it, but
It says it.
It shouldn't say it. I must have hit the button fast next time. So my next one, it doesn't show at all. So who's my next victim that gets to describe to me this EKG rhythm in front of us? So I can see all the names. Is Joe there? Is Joe hanging out?
Joey's not on today. Lakin,
Lakin gets
Heather.
Lakin, are you available to tell me what this EKG looks like for me? Or it's regular or irregular?
Lakin's gonna do chat.
Oh, she's going to chat with us?
I'll tell you what she says.
Okay. I get to look at Stifler while I'm waiting.
Lakin says regular.
All right, and what do we think about the rate? What rate did you come up with, and anything else that would help her identify this rhythm? What would be your good guess?
So rate and then characteristics.
Mm-hmm.
YQRS.
All right, so YQRS, so then survey says generally YQRS complexes tend to be assigned to VTAC. That's the ugly VTAC rhythm. I don't think I've seen too many that ugly, but it is a possibility. The next rhythm I have up here.
Can we go back?
Yep.
So to calculate the rate, you would count 1, 2, 3, 4. Do you count these little skinny notches at the bottom, or these wide bumps at the top?
Can't see my.
I guess it's the same.
Yeah, I understand what you're saying. The peak, you see that you're going off the highest peak, is that what you're saying? I'm going for what's identifying as the complex right there.
So the rate's like 150.
Yeah.
Yeah, VTAC.
That brings up a really good point. If that little peak in the big wide complex, sometimes your monitor will count both of them and actually double your rate. But
Really?
thinks it is.
It thinks it's a QRS.
Yeah.
And like a YQRS, like it would be by Gemini. So it counts both of them and would tell us like 300.
Yep.
Oh.
Yeah, so just be careful. If your monitor says something super fast and ridiculous, that may not be true.
Sounds like you experienced that from before. Yeah.
Yes.
Mm-hmm.
All right, so my next participant, if anybody wants to chat in or see what they say about this rhythm, as far as the regular or irregular, and what rate.
is that me?
Oh, yes, yes, you get to be the next.
Sure. So it looks regular. Looks like there's flutter waves between each rate. It's at 300, 150. It's not fast. I would call that a flutter.
All right, A flutter, Stifler wins again. And then my next victim, let's look at this rhythm as far as rate. Regular, irregular, and rate.
It's regular, it's fast, it's narrow. I don't see necessarily definable P waves, so probably SVT.
Excellent. I love how you described that. So SVT it is, and one Talk about these rhythms, I thought, what can we do about them? So I found this lovely cardio version, Zoll, for you guys to watch. So it's like a 2-minute so video. Hopefully not too many funky ads will pop up in between, but I think has some good information.
Can this
for
tiny
both
cube
guys.
really keep you
I love
cool
these
this
ads.
summer without using an expensive air
This is so
conditioner? A
ridiculous.
former NASA engineer
Like,
and
who's
father
doing
from
this?
Anyways, concierge
Yeah.
from Zoll Medical. Today's Zoll X Series tips and tricks video is going to focus on synchronized cardioversions. So let's take a look. All right, so to successfully cardiovert on the Zoll X Series, the key button that we want to make sure you're aware of is the sync button on the left-hand side of the monitor. So first check to see if the device is in pads mode and you're picking up a rhythm through the pads. Then press sync. The visual indicators you're going to get in cardioversion mode is the sync indicator at the top of the screen is going to flash. And then the peak of the R wave within the QRS complex will have an S above it. And that's going to help the device deliver the energy at the peak of that R wave to hopefully successfully cardiovert this patient. Now, based on your local protocols, that's what's going to dictate the energy level that you start at. A lot of times protocols will say based on manufacturer recommendations. Zoll's manufacturer recommendation is to start at 70 joules. So assuming your device is programmed to start at 120, you're going to press energy select down 3 times so that 70 is highlighted. You're then going to press the charge button to charge the capacitor to 70 joules. Your last visual indicator is that the monitor now says sync cardioversion, press and hold to shock. So unlike a normal defibrillation where I can just tap the button to deliver the energy, I'm going to hit and hold that button in until the energy is delivered at the peak of the R wave by way of that S indicator above the QRS complex. The time that it takes for me to hold that button in will be dictated by the width of the QRS complex that you're trying to cardiovert. You'll notice after the energy is delivered, the sync indicators go away. So if you've not successfully cardioverted that patient and you're going to deliver energy again, it's important to hit the sync button again. And make sure you see the sync flashing and the peak of that R wave is marked with the S. Now in this case, because I dictated the energy level by manually pressing energy select down, when I go in to select it again, it's going to remain at 70 joules, which is what I pre-selected it at. Our recommendation is then to go to 120 joules, press the charge button, and just like the first time, make sure it says sync cardioversion, charge, press and hold to shock. Make sure everyone's clear, deliver energy. Now let's say hypothetically, that didn't work again. And we're now going to cardiovert at the next energy level up, 150 joules. So we go in, we press energy select, 150, we charge the device. Now in this case, you'll recognize the fact that I did not hit the sync button prior to selecting the energy. The monitor says defibrillator. So this patient that you have sitting there talking to you, about to be cardioverted, in this case will be defibrillated instead. So you have 2 different ways to mitigate that problem. One is by hitting the disarm button, which will kick the energy back into the machine and not deliver it to the patient. Or if the monitor is charged up in this situation and you forgot to hit sync, you can still hit the sync button even though it's charged up. You'll get your sync indicator, your S's will come across and march right above the QRS complexes, and then you can go ahead and safely deliver the energy because it says sync cardioversion, press and hold to shock.
So I like to bring that video up because ACLS is going by what the manufacturer recommendation. I didn't necessarily know what your Zoll recommended. I didn't know how many of you guys had experienced cardioversion with the adult population, and I wanted to show the steps. So just recently had a situation where someone tried to cardiovert someone at 200, and so I just didn't know if everybody else was up to date on the speed on what your capabilities for your machine. I believe when you turn on your Zoll, it defaults to 0 joule setting, and then you'll have to go up and synchronize. And every time you had to resync the button, which is a Zoll characteristic. So the next part, I like showing videos because I think it helps explain things better than I can. So cardiac axes is 2 videos listed on the screen. I'm going to show one. I did lie to you last time. It was a 4-minute video, not a 2-minute, but this is another 2 to 3 minute video. The one below it is a 15-minute video that I recommend watching another time that we're not spending together, which has a lot of good information. So we're going to watch this cardiac axes video. And Katie's favorite part, the ad.
Ads. Like, what are these guys doing?
West 24th Street. North corridor, hurry. Coming through. Every second counts here.
The network's got you covered.
Cardiac axis is the net direction of electrical activity during depolarization. In a healthy heart, the net movement is downward and slightly left. This axis is altered or deviated in certain conditions. For example, in left ventricular hypertrophy, the axis is skewed further left, while right ventricular hypertrophy results in a deviation to the right. Cardiac axis can be determined by examining the 6 limb leads, which look at the heart from different angles in a vertical plane. The QRS axis is the most important and also the easiest to be determined, as it represents ventricular depolarization. The QRS axis is considered normal when it is between -30 and +90 degrees. Left axis deviation is between -30 and -90 degrees. Right axis deviation goes between +90 and +180 degrees. The rest is known as northwest axis or extreme axis deviation. Remember that depolarization toward a lead produces a positive deflection. Depolarization away from a lead gives a negative deflection. Impulses moving at a 90-degree angle relative to a lead produce an isoelectric or equiphasic result with positive and negative deflections of similar amplitude. There are several methods to estimate the QRS axis. We will discuss 2 of them. The quadrant method. This method looks at the QRS complex in lead 1 and lead AVF. If the QRS complex is mostly positive in both leads, the axis is somewhere in between the 2 leads, which is in the normal range. If it's negative in lead 1 and positive in AVF, the axis runs away from lead 1, but toward AVF, and is thus in the lower right quadrant. The diagnosis is right axis deviation. A positive value in lead 1 and a negative value in lead AVF place the axis in the upper left quadrant, which interprets as possible left axis deviation. A more accurate method will be needed to further determine if it is borderline normal or left deviation. Negative values of the QRS complex in both leads are indicative of extreme axis deviation. The isoelectric lead method. This method consists of finding the isoelectric or equiphasic lead, the one with equal or nearly equal negative and positive deflections. The axis line is perpendicular to the direction of the isoelectric lead. Next, look at the lead that runs nearest to this line. If the QRS complex is positive in that lead, the axis points to roughly the same direction as the lead. If it is negative, the axis points to the opposite direction.
All right, to recap, being able to recognize cardiac axis deviation is important because the heart, what calls electrical conduction.
America was built on hard work and honest competition, but Visa, MasterCard, and their mega bank partners are...
Turned all the other ones off before. So let's do some cardiac axis practice.
Can you explain to me this part? Yeah.
Oh, yes, so this is, when you look at a EKG, you should be able to see the complexes an upward deflection. So it will go down go down to the past the isoelectric line, and then when it returns to the T, above to the isoelectric, it will go above or normal. Does that make sense at all?
So are we only looking at 1, 2, and ABF?
Yes.
Okay.
It's recommended 1, 2, and ABF.
Okay, and they should all be up.
It should be all be up. So it's a normal access. So here is my lovely assistant Danny, that's sitting in the background, is going to tell me what he sees on the EKG for me.
I am seeing 1 looks like it's positive or up, 2 looks like it's up, and AVF looks like it's up. So that looks like normal access.
I figure you're the most normal person on, so I'll ask that one first too. So.
Oh, that's a big assumption, but.
Yeah. So moving to right axis deviation, we see that the QRS complex is more downward deflection. And then for lead 1, for lead 2 is an upward deflection, and ABF is upward as well. So I guess it's back to Gwen, since I've heard from everybody else. Oh, Katie has a question.
You taught me right reaching,
Mm-hmm.
right? That 1 and the 2 are reaching to each other. Right reaching is a right bundle branch block. Is that right?
Yes, that's right, but I didn't think everybody else would enjoy that thing.
Oh, I like right reaching.
You like right reaching? What do you do?
I do the thumbs with it from showing community EKG.
Yes. Thumbs up means right. Okay. Yeah.
Okay.
It's everybody's a little different. The right reaching. I figured that would be easy. All right. So Gwen, here's my EKG. Read it for me, please.
So 1 is downward deflection, 2 is upward deflection, and ABF is upward deflection, right? That's what I'm looking at.
Yep.
Sorry,
correct.
screen's little,
You don't-
I'm blind.
That's okay. Here's my next victim. Is it Lewis again?
You didn't call him Sally. Sally's back.
Oh, Sally's back? Well,
Sally's back.
all right. So Sally, we're on left axis deviation. Our QRS complex for lead 1 goes up. For lead 2, it goes away. So left is leaving. That's my mnemonic for that. And then AVF is leaving as well. So on this EKG, Sally, please interpret it for me. Better with IT than me.
Everyone's better with IT than you.
Okay.
She might be typing.
She's typing. We should play Jeopardy music while we're waiting for the answer.
That's fine.
Do we have to pass? Does Sally know she's on the spot?
*6, unmute yourself.
Oh, 1 is up, 2 is down, ABF is down.
Thank you very much. Up, down.
Down.
So they're leaving, so we got example of a left axis deviation. So this bad boy, extreme axis deviation, is rare. It's when everybody's going down. I do not have a good example of that, except for a tricky 12 leads to interpret. I'm going to have my lovely assistant, Josh, do some interpretation for me on this guy right here.
So this one we can kind of look at it step by step. So first thing we talked about was like the P wave, the QRS complexes, all this. I'm gonna look at those first. So my P waves look normal. So probably a sinus of some sort. All of my QRSs look like they're narrow enough. Next thing I'll go is my T wave. Some of the T waves look a little funky, so we can come back to that. Next thing I personally look at is that axis deviation. So the AVF is down, lead 1 is up, and lead 2 is up. So I have some sort of left axis deviation. The next thing we're going to look at is V1 and V6, especially with the left axis deviation. That usually tells me it's going to be some sort of block. So I can look at how wide V1 is. If that'll tell me, it looks like the QTC up there is a little wide. Where's my QRS? 0.94. And then looks a little spiky, and the V6, the T-wave looks a little funky. So probably some sort of something going on definitely on the left-hand side, maybe some left ventricular hypertrophy or some sort of block going on. So that's how I'm going to get to that point.
So 28-year-old male, only complaint of diaphoresis and no previous cardiac history.
Was this your patient?
So what would you determine, would you think this would be something that you would consider cardiac in nature or medical history or physiology versus pathophysiology?
Being that young, probably not cardiac in nature, could be patho or it could be some sort of previously undiagnosed, especially with the potential of a block or left ventricular hypertrophy.
So when you first get that 12 lead, does anyone feel fuzzy about it?
Like, do I like it?
Yes.
I mean, all the T waves are inverted, right? So that's a bummer. And there's the away, up, down. So that's not good. I'm glad that the QRS complexes are narrow because he's not in a ventricular rhythm. But it seems wonky. It's still wonky.
Still wonky. So just specifically that when your axis is off, you'll see it through the whole entire EKG is what I would like to highlight part is when it's off everywhere. That make sense?
I don't understand what you're saying.
When your axis is off, your machine is going to read it wonky. It's not going to be able to give definitive answers.
Your axis being off hurts the machine's ability to give you a good interpretation.
Right. Makes sense.
Got it. So the first thing you should check is axis because what the machine spits out, if the axis is off, is going to be not exactly right.
Correct.
Got it.
Why I will say abnormal.
You'll just say abnormal EKG instead of STEMI or because it can't interpret a STEMI in.
It can, however, it's not going to be as accurate. I'll qualifiers later on.
Okay. I'll wait.
Yes. Actually, all right.
Hey, Brandi.
Go ahead, boss.
Do you mind if I expand on axis deviation a little bit?
Yep. Go ahead.
So I recently had a preceptee ask me why it's important because no one seems to know. So the way I explained it is we know that left bundle branch blocks are bad. And especially if they're new, that could be a sign that there's cardiac damage, there's something bad going on. So the left bundle branch consists of two fascicles. So two pathways that go down into the left ventricle to depolarize the left ventricle. The right bundle branch is only the one. And we know the right ventricle is smaller. So you have these three pathways into the ventricles for depolarization. When you have the left bundle branch block, two of those three are blocked and are not transmitting signals down into the ventricles. When we look at axis deviation, we're looking at the two branches of the left bundle branch independently. Because if we have a right bundle branch block plus one of those left branches are also blocked, we can call that it's a bifascicular block, and it's the same as if you have a left. So if you have a right bundle branch block, which you have a wide QRS and an upward deflection in V1, plus your axis is either right or pathological left, then you also have a blockage of one of the two in the left. That plus the right is a bifascicular block. There's something bad going on.
Yep.
So it's a precursor to a complete heart block, and that's how you kind of predict that.
I do have an example of one later on, and that also that 16-minute video exactly explains that process because it is the base of the cardiac axis, let alone the issues of the bifascicular block is a lot to, I think, compute first time around or two to see. But yes, we have an example for you as well.
Yeah, I uploaded a third attachment that has like 1 million YouTube links that Brandi recommends.
1 million, maybe like 5.
It's like 5, okay. But anyway, if you have time to watch those, it's extra credit. There's no extra credit. It's extra credit because it's going to explain this stuff in way more detail. But yeah, thank you, Louis.
I know which ones, rhythms to give him to interpret later on. This is another video because I like videos, but we're going to skip into the 2 minute and 22 seconds to review EKG, obtaining EKGs on the 12 leads on the Zoll.
To open the 12-lead ECG screen. This provides a diagnostic filter view of all 12 leads on the screen to check the quality of the tracings before the 12-lead ECG is acquired. To acquire a 12-lead ECG, press the 12-lead acquisition icon, Camera 12 button. The X-Series Advanced can be configured to prompt the provider to enter any patient information. This is only done prior to the initial 12-lead ECG. After entering the required information.
So I was making notes to talk later, but two people in here decided to chime in.
Sorry.
The Zolls are not programmed to request that information, so on the side, make sure you hit the little clipboard below the 12-lead picture and obtain the, put the current patient information in.
Do you also want to talk about how it can be in adult mode?
Yes, and then because the adult mode is the only way that you're going to access the 12 leads, so when you turn on your machine, you make sure you click the little button to go up to the adult to be able to have the access to a 12 lead.
Because ours default to pediatric.
Press the 12-lead ECG acquisition key a second time to begin the process. It will take 10 seconds to acquire a 12-lead ECG. If needed, a stop key is available during the acquisition, which will cancel the acquisition. Once the acquisition is complete, the X-Series Advanced will save the 12-lead, provide the Innovise algorithm's interpretive statement, display the interpretive statement on the screen, and, if configured to do so, begin to print a copy of the 12-lead ECG. The screen will be split into two views. The left is the analysis page and shows information related to the newly acquired 12-lead ECG and the Innovise algorithm's interpretive statement. The right screen is real-time view, defaulting to the live view of leads 1, 2, 3, AVR, AVL, and AVF. Press the 12-lead Review Next key to advance to the next analysis page. This page provides patient information as well as related measurements, including STJ measurements. Pressing the 12-lead Review Next key a second time will display page 1 of the 12-lead ECG snapshots. Note that leads 1, 2, 3, AVR, AVL, and AVF from their acquisition are shown on the left, and the corresponding live view of the same leads.
So I have modified literature about the Zoll. The reason why I like this part is because the direct comparison that there's actual real-time changes from a previous 12 lead to what's currently going on. So being able to go back to see if the changes are occurring in front of you is something that the reason why I like that dual screen.
Is shown on the right. The X-Series Advanced records a full 10 seconds of each lead and divides into 4 separate 12-lead snapshot pages. Each page represents 2.5 seconds from the acquisition. Press the 12-lead Review Next key to scroll. To view leads V1 through V6 on any of the snapshot pages, simply press the Lead Select button to toggle between the two sets of lead views. Press the Print key to print another copy of the.
Right, so that's all I guess wanted to really go over for that. It's just the acquiring of it. Find the cables buried back in this pouch on the right side was a lot of fun. And then where you can find the data that is programmed or relative relating to your EKG because it'll print out the numbers. Yes, ma'am.
All the data that it printed on the second page of the interpretation, did it print in that EKG strip you printed? All of it?
Yeah.
Okay.
So the same data you'll get on your screen is the one you print out.
That's interesting.
Have you ever paid attention to it before?
When I used the LifePack 15, I used to pay attention. I honestly, I can't remember the last time I got a 12 leader in a kid. But I like the data.
So the ZOL is set up for obtaining 12 leads for anyone over the age of 18. It's not designed for rhythms under reading EKGs under that age because of why there, Josh?
There's no FDA license to interpret EKGs for under 18 years of age.
So that's why it's important to have people put the right information in for the patient, because the AHA recommends guidelines based on the algorithm, so the ST elevation thresholds, it will determine based on the standards of what they recognize. So each age group has a different voltage parameter. So a female has a lower threshold, and a 40-year-old male to 18 to 40 has a lower threshold than a older male has a higher threshold. So what would be considered elevation for a female and male is different, as well as different age brackets.
And it will tell you that on the printout, right?
What you put in. If you don't change the information, it's gonna default, your machine defaults to a 45-year-old male.
Oh. So it would even be helpful if we left it at 45 if we're doing like a 13-year-old, but change the gender?
I would change it to a more appropriate age.
You would put the right age and the right gender in. It'll still interpret because you're in adult mode. Okay, so ignore the age. It's just for data, for labeling. I just want to make sure it wouldn't not interpret my data because I put in 13.
No, it would not preclude it because of the age.
It's the mode only. Got it. Thank you.
So just things that we're looking at for as the goal in the 12-lead mode is looking at the ST segments for the elevation numbers that we're looking for, and also depression, and then the other different ST segments that we may see, maybe the previous cardiac ischemia, cardiac abnormality, stuff like that. So the example I'm showing you that the 12 lead may not necessarily recognize the previous ischemia, may say H undetermined, but it will try to pick up the elevation and depression when it goes to read the information for you. So just to review, when we print the 12 lead out, these are the areas of the heart that we will see. Your lateral leads, anterior and septal leads kind of grouped together, and then your inferior leads. So just a good practice is when if you did have to print out the paper ahead of time, just get in the habit of labeling on your 12 lead the parts of the heart that you're going to be visually that you're looking at. Just be able to help diagnose what's going on. If you see depression in leads V1 through V3, suspected posterior infarction, then you want to make sure that you do your 15 lead ECG by replacing 4, 5, and 6, V4, 5, 6 back on the back for V7, 8, 9, and then redo your picture, redo your 12 lead, and then it'll show you an example that you possibly have some ST elevation for V7, V8, V9, if you see depression in V1, V2, V3. My lovely assistant Josh is now going to tell us, or do you want to show him? You want to show your little 12 lead body technique?
Yeah, if you want to go back a slide,
Mm-hmm.
the slide, 2 slides where that picture was.
That one right there?
So, you know, whenever it calculates all these things, it's very important to have proper positioning of all your stickers. The whole program is designed based off exactly where on the body the stickers are located, where the normal heart sits. So it's important to get the actual positioning of the stickers correct. So you notice V1, V2, they're right down in the sternum. Sometimes that can be kind of hard to find because you can't really feel your ribs in the upper part. What we can do is that little notch you feel right above your clavicles, right in between. If you feel down just a little bit, see where that kind of square part of your sternum is, that's your manubrium. That ridge, right where that little skinny part almost looks like a necktie, with the knot of that necktie and the long part come together, you can feel that ridge. You go over to the side just a little bit, that's your second intercostal space. So you go from that ridge right over, that's your second intercostal space. You can feel down from 2 to 3 to 4. that fourth intercostal space just to each side of your sternum is where V1 and V2 go. And then you can measure out from the other ones from there. So you're going to do V1, V2, that's your fourth intercostal space just to each side of your sternum. The next one we're going to place is actually going to be V4. V4 goes right in that mid-clavicular, so you measure from that clavicle from the inside over to the outside, split it right in half, and measure right down to that V5, or excuse me, that fifth intercostal space. That's where V4 is going to go. Next, V3 just goes right in a line between 2 and 4. And then as you follow V5, stays in that fifth intercostal space. We're going to stay in that fifth intercostal for all the rest of them. The V5 goes at what we call the anterior axillary line, where your armpit kind of starts, that angle right there. Goes down to that fifth intercostal space. And then 6 goes at mid-axillary. So if you look up your armpit right there in the middle of it, right there on the fifth intercostal space. And if you notice, it actually starts to curve back up. So if you see stickers that go downwards all the way across the chest, that's incorrect. It should be following that fifth intercostal space for all the rest of them.
So I've read that the tendency is people sit next to a patient and don't have the patient roll completely to get a true mid-axillary. So the tendency is to squash your 4, 5, and 6 a little too far up on the chest, and then it should actually be like a true mid-axillary, and you might have to roll your patient over a little bit.
Yep.
Yes, getting very close contact and lifting things up and sticking things around its place is very important, because the algorithms that these machines are programmed with are very specific, and if it's don't have good lead placement, it's not going to interpret the data correctly. All right, so I think we're moving on.
So, and then you would cross out 4, 5, and 6 and write 7, 8, 9. Like, you can't change it on the monitor.
No,
Not on ours.
Not on ours.
Yeah. You print it out right on it what side it was, and it's the same thing as if you're going to do the V4R to do the right side.
So 1, 2, 3 depression equals do 7, 8, 9.
Mm-hmm. All right, so I think my next victim is Lakin to do rhythm interpretation. Is she on by chat, I believe? Is she ready for this 12-lead interpretation?
Oh, Sally has a question.
Oh, Sally.
How accurate do you find placing V4 mid-ax line at crease of breast to chest for women?
The best way to answer that, as long as it's a reasonable size, typically the underside of the breast tissue meets right there at that fifth line.
Mm-hmm. It all depends on size. If it's
So like a woman, you would say like me, 5'6", you weigh like probably less than 180, are not overly large chested, then it could be predictable. I like to feel ribs under the armpit sometimes.
If the breast tissue is pure breast tissue, not adipose tissue, it meets at the fifth intercostal.
Check. Thank you, Josh, for that interpretation. All right, Lakin, chat away. Brandi, what questions do you have for Lakin?
On this 12 lead that we have in front of us, do we have, is it regular, irregular?
One question at a time, regular or irregular?
All right. I'd like to do it all.
Yeah, but then she's got to type like 17 lines.
Oh, I forgot she's a typer.
Regular, check.
All right. What do we think about the cardiac axes? What do we think? Is it normal, abnormal?
So we look at 1, 2 ABF, right?
Yep.
Just because I need to remember. I'm not going to start to be embarrassed of my current skills.
And then just off the bat, what does it look like as far as if she had to just give it a rhythm name?
So axis and rhythm name.
Next victim is going to be Danny, so Danny can be ready for the next one.
Front attack.
Okay.
What did you think about 1, 2, and AVF, Lakin, with the axis.
Normal, right, or left?
I think it's up, up, up.
Yep.
Leaves it a pass. So I think it's up, up, up.
And then, do we see any ST elevation?
Lincoln, is there ST elevation? So I don't think I see ST elevation.
Right. So, there's.
Right, Lincoln says no.
Yep, no ST elevation present. This is a, NSTEMI. They may be having, some type of chest pain event. That's not completely occluded, so they'll have presenting signs, but there's not necessarily anything on the EKG, to represent those changes just yet, and it may change later, so that's why the importance of doing a 12 lead early and then, retaking a 12 lead. You know, if your machine doesn't pick up the changes, you should at least print out, if you suspect, every 5 to 10 minutes, so you can capture the changes.
So what did we talk about earlier? It recaptures automatically every 5 minutes
I believe it's every 5 minutes.
if you leave the leads on. So you could just leave the leads on and it will just recapture and spit out another 12 lead?
You have to prompt it because it's not going to tell you the changes. Some machines can say there's absolutely something going on.
Right, I know Physio product
Yeah.
will, if it senses the changes, constantly passively monitoring. And if it senses the change, it will print. Ours does not do that.
Yeah.
Okay.
All right, so now I think Danny's on the hook for the next one.
So what's the first question?
We're going to start the basics as far as regular, irregular, what do you think the rhythm is? You just say slow.
It looks a little slow.
Okay.
It
And
looks regular. The QRSs look regular.
Okay. What do we think about the axes?
It looks. I don't see AV. Oh, there's AVF.
Where's the amplitude
One
bigger?
looks like it's pointing both ways.
Okay.
2 looks like it's up. And then AVF kind of looks like it's pointing both ways.
Okay, so are you sold on it being more than not normal, or are you sold on it?
I'm guessing it's not normal. It doesn't look super normal to me.
All right, so we'll say abnormal, so go ahead. What do we think far as elevation?
I think I see elevation. It looks like elevation in AVF. I'm seeing lead 3. I think in lead 1, it kind of looks like depression.
Okay.
And then lead 2, I guess looking at like the second beat, looks like maybe a little bit of elevation.
Okay. So what part of the heart, if you were to label, what part of the heart do you think is being involved?
That's a good question.
Yeah, I wish you were
Where's
here.
that chart?
The chart is on the thing, so you want the chart?
Who's the PDF? I see
All leads, but
all leads. What's I? Inferior?
yeah, where is?
Am I right?
So inferior, yes. Yeah, same thing. I take my little lead out, draw my little.
One
heart.
sec, I'm looking at my diagram here real quick.
Mm-hmm.
Look at your diagram.
So 3. So I think inferior. I'm
Survey
guessing
says-
inferior leads
inferior, and you'll see the reciprocal
and then
changes.
anterior.
Inferior, so inferior is the bottom.
Mm-hmm.
I'm really bad at this.
Yeah.
So then you would expect them to like, so anterior is like this way, right? So that's why we have reciprocal changes in anterior, because it's opposite.
Mm-hmm. Okay, so it's depression in V2, V3, V4. All right, my next victim I've got to get on the board is Heather. Heather, are you available?
Yep.
All right.
I don't know how I'll do,
All right.
but I'm
Let's just-
available.
We'll start with the first things, what we think about the rhythm, regular, irregular. Looking through it.
Yeah, I'd call it regular. And 1, 2, ABF look like they're pointing up to me. V,
Normal act.
yeah, so normal access. V2, and I can't tell whatever the one under V2, V3, I guess. Maybe 4 and 5 also. I think the T wave looks elevated.
Okay. So what part of the heart do we think is being affected?
That's what I was in the middle of doing when you
Okay.
when you called me. I was trying to find the piece of paper that had the thing that says which of these match to which part of the heart, because I definitely don't have that memorized.
Yeah. It's just a force of habit of once you put your 12 lead out, it's just to ride it, consistently riding it in where the affected areas are at.
So I see all leads. So I is 2, 3 ABF, right?
Mm-hmm.
C is B1 and 2.
Mm-hmm.
All is 3 and 4. And leads is 5, 6, and 1.
Mm-hmm. And ABL.
Oh, and ABL. Right. So what did you say, Heather? 3, 4, and 5? Or I guess it's
2, 2, 3, and then 4 and 5.
Yeah. So it's like I see all. So it's like septo anterior,
Survey says.
right? And the nice thing is you can just look at your STJ, right? Does the 12A print out the STJ for us?
Look on my screen.
Your screen has the STJ. I'm asking, does our 12A
Yes.
print out
Latvia.
STJ?
STJ bottom measurement.
Yeah, so our 12As print out the STJ. So you can see, like, on this 12A I'm looking at, it printed out many zeros, but then also some are 2.67 millimeters.
So this one, when Kate's referenced the STJ, the ZOL is programmed to identify a STEMI when it's above, a female above 150. So when you can relate the numbers, anything above 150, it's elevation, because looking at something on a piece of paper, how well you can tell it's elevated. But if you knew that women don't pronounce a STEMI until they're above 150 on STJ, does that make sense?
Well, ours is in millimeters, so I guess that would be 1.5.
Mm-hmm.
Okay.
Yeah.
Thank you.
All right, my next victim, I can't remember if Sally's turn to go up again or if we're back to Josh.
Where's Gwenny?
Gwen just did something a minute ago. Gwen can go.
Oh, good. Can I?
Yes, here's your strip.
Okay, I'm just gonna tell y'all I couldn't print out the thing, so I'm gonna need help. It looks like up, so normal axis. It looks like a normal pace. It looks like okay, what am I missing? Because it looks.
Is 2 and 3 elevated, Gwenny? Maybe ABS?
Oh, the T, yeah, is above the axis. So 2 of a T elevation. Is that what we're going for?
Yeah, ST elevation. I think it's.
But 4 and 5 do not. Right?
Do we see reciprocal as well?
4 and 5 would be the reciprocal depression.
Yeah, so they don't have, they look pretty normal, right?
I don't know if the reciprocal is the 2, 3, and ABF. What's the reciprocal?
2, 3,
The
2
school?
are all elevated though, so that's inferior.
Inferior. So there is a lead on here showing depression. Do you anybody recognize what lead is showing depression?
ABR. Sorry, I'm on my laptop and I'm blind.
Fine. So ABL shows a little bit
Oh, yeah, I see it. Okay.
small, but it's just enough to indication. And then because those two contiguous leads for the elevation, even small, it's still saw that stemming for the inferior. So then this will be a patient that we will do the remove our V4 over to do a right-sided, so we get another picture so that you can get the.
So inferior, you do a right-sided.
Mm-hmm.
1, 2, 3, you do 7, 8, 9.
V1, V2, make sure you say.
V1, V2, V3, you do V7, 8, and 9.
Right.
Okay.
But this one we would do right-sided? Is that what we just said?
Yes, yep. So if you have indications in ST elevation, it may be, if you've got, this is a very small section of the right side of the heart that you're looking at. So if you were to move to V4R, you'll have a better picture and you'll probably see the elevation quite obvious once you move over to.
So you think V4R would look much bigger elevation?
Right.
Or I might just kill an adult. Yeah, either way.
No. You necessarily won't kill him. All right, so who's my next victim? Is Sally back around?
Sally is here.
All right, Sally, you have a, let's give her some information. She likes to have stories. This is a 50-year-old male in front of you. Tell me what you got.
Regular rate.
Mm-hmm.
To ABF up, so normal access, yep. ST elevation 2, 3 ABF. 2, 3 ABF. 3. Katie agrees. I don't know how much that counts. Josh is shaking his head.
Yeah, so what part of the heart feels involved?
Part of the heart?
Mm-hmm. Exactly. Where's the infarct happening with your ICL leads?
I'll let Sally answer.
Okay.
So Josh, while Sally's answering, when we go to MedStar, we go to real MedStar. But yeah, Sally's right, it's inferior.
Thank you very much.
We go to real MedStar for a STEMI instead of the stupid ER.
Yep.
Okay. So because it's inferior, we should do a right-sided again, like you said?
Mm-hmm.
Okay. I just have to remember these little tidbits.
So my next person is going to be, is it time for Josh to be back around?
I would love when Josh does this. Josh's turn. Josh.
Hey, Josh. All right.
You're the only Josh on.
So first thing I look for is P waves. I do not see any P waves in this one in particular. It looks to be a regular rate. Next thing I look at is 1, 2, and AVF. So 1 looks down, 2 looks up, AVF looks up. So I'm going to have a right axis deviation. Next thing I want to look at is V1 and V6, since I have an axis deviation, and I see the little bunny ear things, but not a normal right axis. So it looks like maybe some sort of potential left axis or left bundle branch block for the right axis, so maybe some sort of partial fascicular block. The next thing I see is this T waves in AVL, V2, V3, a little bit in V4. So that all looks like it's upright in the anterior. And then I see some what looks like depression in lead 2, lead 3, and V6. So it looks like our problem's going to be mostly anterior, but probably like high anterior with the reciprocal changes in the inferior leads.
So let's go back to that bunny ear you mentioned that you just decided to smooth over. So where's everybody looking for those bunny ears at?
So if you're going to look for bunny ears, we're going to look in V1 is the best place to look for it. Sometimes it also shows up in V2. But I look for V1, you see like that little notch. It's almost like it's 2 QRS complexes squished together, which essentially is exactly what it is.
I need a pointer on this thing to be like, this is what you're looking at, the bunny ear thing. Did anybody not see the bunny ears, so we clarify?
Hold on. There used to be a way to do a pointer.
Oh, annotate.
Annotate. Where's the annotate? There you go. Circle the bunny ear.
I'm trying, but the bunny ear is just not looking to be.
Doesn't want to be seen.
Yeah, if you undo the notch. Notch.
Yeah, it's almost like
If in V1, there's like 2 downward deflections.
I guess it's just it's like a little blurry. So, and then the right axis deviation, you're correct on that as well. Let me go up the slide so everybody sees the same information I'm seeing.
I just shared in the chat a thing about axis deviation that Lewis sent me.
Lewis likes this stuff.
I don't know if you can open it. Let me see if I can save it as a PDF.
So the notch, the bunny ear is indication for?
it's an indication for bundle branch block. And depending on which way it deflects first, there's going to be a left or a right.
So the signal, the QRS, little double QRS is going down, so we're going to go with right hand
It's a left.
or left hand?
Yeah, I think of it as like the turn signal rule.
I would say that, so left hand.
So if I push down, I'm turning to the left hand. If I lift up, I don't know if anyone knows what a turn signal is.
Yeah, it's,
You do in the back.
yeah, okay.
But turning it down, so my very first deflection is going to be down. So the left bundle branch, but that's not normally consistent with the right axis deviation.
So this is an abnormal EKG, which you'll very, very rarely see or not too often.
Yeah.
So, point is that you can note the ST elevation is prominent throughout, and you have reciprocal changes where it needs to be. So, the next hard one is going to be for Lewis, I think. I think Lewis is always.
Can you help me with the bundle branch block thing, though? So you see the bunny ears, right?
We need to highlight it again, or what the question?
No, I see the bunny ears.
Okay. The bunny ear goes down.
It's not so much the bunny ears themselves go down, but the very first deflection off the isoelectric line is to down. So think about
So instead of going up, it goes down.
Yeah.
So if it goes down instead of up, probably a bundle branch block.
It's probably left bundle branch.
Yeah,
Left bundle branch.
I have another picture later on that you'll probably see.
Oh, there's more?
Yeah, there's more.
But that's why I
Sorry.
talked about the turn signal rule. Like if you push your turn signal down, you're turning to the left.
Mm-hmm.
But if you push your turn signal up, you're turning to the right.
And V1.
Oh, down is left, up
Yeah,
is right.
and V1 is able to take the picture where it splits in the heart, and that's the best example of where it would be at. Makes it.
Yeah, and you're doing the turn signal if you have a wide QRS. And that's why you're seeing that those two downward deflections, the R wave and the R prime. So that is kind of the two ventricles depolarizing at not exactly the same time because you have that heart block, and that's why it's elongated.
Mm.
So then you go to the J point, which is where the ST segment begins, and that's when you would shade, is it going left or is it going right, up or down?
So really, I need a part 2 on spending 2 days on bundle branch blocks.
I don't think so, because you just gotta be able to see that there's a block. And you don't necessarily need to know exactly about it. I think it would be more time consuming.
Oh.
You know what I'm saying? Like, what else are you gonna do with it?
In the 30 seconds it takes me to get to hospital center.
Yeah.
Right bundle branch blocks are non-life threatening. Sometimes they're just there because they're there. Left bundle branch can be life threatening.
So it's more important that I recognize the downward deflection of the left bundle branch.
Yeah.
Okay.
And there's more into diagnosing a STEMI in setting of left bundle branch or paced rhythm. You use Scarbosa criteria, and that's a whole nother thing that is probably beyond the scope of this.
Yeah. We're just looking to be able to identify some basic concepts. So I think, Stephanie, since you're on, there you go. Here's your EKG.
Okay. Let's see, 300, 150, 100. It's just below 100 for a rate. It looks to be narrow complex. They might have some left ventricular hypertrophy. Got some bigger QRS complexes. It is regular. I see P waves. So I'm going to call it normal sinus rhythm. It might be borderline tachycardic, but our axis deviation is normal. 2, 3, AVF, we have some depression. V1 and V2 look relatively normal. Depression, 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 depression. And AVR is elevated. All right, so AVR is elevated. It's greater than that of V1, and we have global depression. So it could be an occlusion. It could also be sepsis. It could also be a number of other things that's causing subendocardial ischemia. So yep.
You're going right there. So tell me what, or medical history, right?
Yeah, so this really depends on what the story is, as to, we could call this an AVR STEMI because we have the elevation in AVR, it's greater than V1, and then we have depression elsewhere. But that elevation can be caused by so many different things that it's really story dependent.
Right. So this is an example of an ugly looking 12 lead that is going to be based on signs and symptoms presentation, as well as what's going on currently, and that AVR is abnormally to be elevated.
So AVR elevation is shenanigans and can mean so many things.
Yeah, but the problem with it is, like, maybe only like 10% of those are actually STEMIs. The problem is, if they are STEMIs, they're really, really, really bad STEMIs. So.
And I don't think they'll have this high of a heart rate as well perfusing adequately.
So patients will tell you they're having a STEMI because of the signs and symptoms.
Pretty close.
Yeah,
Here's
so
my,
if this was like a septic patient and they're tachycardic and they have a temperature and they fit the bill, they have a source of infection, and they have this EKG, this is probably caused by the sepsis, but we can't make that determination. They'd need to do like troponins.
Got it. All right, my next victim. When's the last time I talked to Danny? Has it been Danny been a while?
I'm here.
All right. There's your EKG, sir.
Lead 1 looks up, lead 2 looks up and down, AVF looks down. First off, it does look regular.
With that part,
It looks regular.
Okay, perfect.
What else? QRS looks a little bit wide.
Yep.
And then if we wanna, I guess I'm seeing like some elevation in like V1, V2, V3. It looks like some depression in AVL. And
It's ugly EKG, is that what you're saying, Danny?
yes, I don't love it. I don't love it.
Right. Survey says, patient has a left bundle branch block, and yes, you're right, QRS is elongated, as well as some ST elevations in V1 to V3.
Can we see the left bundle branch block in V5 and V6?
Yeah, that's the bunny ears.
Yeah. Well, and
Okay.
then I see it, I guess, in 2, 3 ABS, right? Those are notched, and maybe AVL. Those all look notched to me. So yeah, I'm just saying what I say, Danny. I'm not saying I'm right.
I was going to ask the same question.
It's another example of an ugly EKG because the patient has
The bundle branch block.
right. It's an ugly EKG.
So you can't really determine anything in the presence of a bundle branch block until you look at Scarbosa criteria, which is a whole nother day.
And guess what?
What?
Treating the patient for what they're presenting.
Right. So in the 30 seconds we're going across the street, if we think they're having a STEMI,
Yeah, it'd be more obvious in this one.
it'd be more obvious than this piece of paper.
Yeah. Some people just have normally ugly EKGs.
EKGs. Okay.
I guess Gwen's up and running. Where'd Gwen go?
I'm here.
All right, try it again. Right.
So it looks regular. It looks nasty. Definitely 2 and 3 have elevation. And is that a bundle branch block too?
Yep, so that's why I put them back to back, because then you can see you definitely have a bundle branch, but you definitely see that ST elevation in this picture, how
And
and where.
And in AVI.
And then you see reciprocal somewhere.
Depression in AVL.
Okay.
And what is that elevation in 4 and 5?
Let me see the numbers. I don't think so. 4 or 5. No, it's not calling it. It's not.
Okay,
It's
so
not
depression in
calling.
1. Right? All right.
Yep. So what part of the heart, would you
So
call
the
that?
elevations in 2, 3, and so that's inferior, right?
Right.
Once again, I'm
So then
trying
we
to.
do V4R.
What's that?
So then we do V4R,
Yep. And then you have some ABL,
depression.
yeah.
Yeah.
So ugly, another EKG, but example of, when someone's got a left dental branch that's going wrong. Having an MI at the same time. All right, when's the last time we talked to Lakin?
Lakin dropped off.
She dropped off,
She doesn't like us anymore.
all right, so, Heather, is Heather still hanging out?
Yep.
Heather. Oh, goodness, Heather, let me flip my page.
All right, let's see. Looks pretty regular. Looks narrow. Looks not terrifically fast or slow. I see P waves. 1, 2, AVF all look like they're pointing up. So axis is okay. I don't think I see any bunny ear things. And then to me, it looks again like 2, 3, 4 of those T waves are probably pretty peaked. I don't know how the reading comes across, which would be anterior.
Okay, anterior, survey says anterior, you picked up the elevation V1 through V3, up to V4, and then the reciprocal changes, 2, 3, and ABS. So I think that's all the hard ones I have, or the only EKGs I had to go over today. We've extended our time a little bit, so.
A lot of EKGs.
It's a lot of EKGs, but it's good practice. Key points, what we learned today. Zoll, mindful of the synchronized cardioversion in the right joule setting.
So 70 joules for an adult for the Zoll.
Yeah.
I didn't really know that.
Then we talked about cardiac axes. Sometimes it's good to verify the axes, because if you got an ugly EKG, you'll know why it looks all the way through ugly, because you turn the axes, as well as this bunny ear situation, these bundle branch blocks that you guys get caught up on. And then we talked about, what was the other exciting thing to differentiate?
We did rate, axis, ST elevation, reciprocal changes, the area of the heart, ICL leads.
Yeah, we're still gonna get better at that. You know, you'll need to have a little business card, put on your little thing that has all that stuff.
Another badge buddy?
Another badge.
We could put it in the protocol app, an ICL lead diagram.
Yeah. But other than that, I can't think of anything else. The other videos, like you said, the 16-minute video on cardiac axes has a pretty good explanation of it. And you said Stifler sent some stuff to you.
I dropped it in the chat.
Okay.
The axis hemi-block chart.
Okay.
But yeah, their 16-minute video is good. She made me watch these videos, guys.
Okay. So anyway, I don't have anything else unless anybody wants me to beat them up anymore.
Does anybody have questions? I just now think I need to practice more 12 leads. I dropped the course eval in the chat. So click it before Josh boots you out of the meeting.
And then they have a test.
And then make sure you print off the worksheet and do the 10 questions and send it to Josh, either via email or the mailbox is outside of our office cell down, so you can just do the old slide under the door, Jobby. Or text the picture to me and I'll email it to Josh. I'm sure you can text the picture to Josh. I'll figure it out. That would annoy him. Don't do that. Okay. Does anybody need anything before we peace out?
Thank y'all.
You're welcome.
Thank you. Could you hear me?
I can hear you now, Sally.
Yay.
Oh no, Sally couldn't talk to the whole thing.
Thanks, Brandi.
All right. Bye, guys.
I feel like if we did about 100 more of these, I'd be comfortable.
I was thinking the same dang thing. I was thinking if this was like an everyday occurrence to read them, because this is, you know.
Maybe we'll do more 12 leads in skills, because next year we're going to the 12-hour skills days, so maybe we'll spend an hour doing.
12-hour skills day.
Yeah, but only twice a year. It's actually probably going to be 10 hours plus 2 hours for people who need.
Yeah, I think 12 leads is an in-person thing. This is can be done good by Zoom, by interaction for people, so that everybody can talk it through, because you don't see it unless someone else sees it sometimes. But
yeah, so
Hey.
maybe we'll put 12 leads on the list for skills.
Hey Gwen,
Yeah.
when I have a preceptee at work, I walk around with a bunch of 12 leads in my pocket and I hand them to them throughout the day. I can start doing that with you if you want.
Absolutely. I'll do that.
Uh-huh.
All of us. Sign us all up for that, Lewis.
Yeah,
What is
right.
your- Not to keep, sorry, but what's your all indication for doing 12 leads?
Like a 6-year-old dude in the ER with chest pain.
Y'all do any-
Anybody with chest pain can have a 12. You can do 12 leads for anything you
Because I
want.
say don't do it on all your seekable patients.
No, kids pass all the time for real dumb reasons.
For adults, I'm talking about for adults.
Oh, yeah.
Oh, they should do it. Sally
But also
we had a
what happens-
patient they did nothing for.
The 12 lead, if they do a 12 lead in our ER, it gets taken and interpreted on the 12 lead machine before we even get there.
Okay, never mind.
And the doctor is like, oh, it's normal, and nobody looks at it.
Okay,